Some tips to orient pedicle groin flaps, that is in the Journal of Hands and Extremities, and he has also experience of 39 peroneus brevis muscle flaps for reconstruction of distal leg and ankle, published in IJPCS, and also he has published reconstruction of segmental defects of Achilles tendon. Is it a must in infected complex defects? Now we have him here. At present he is working as unit chief in the Department of Orthopedics, that is in the field of hand and microsurgery. And today we have him to deliver a lecture on neuropathic plantar ulcers. Ulcers as such are difficult, more challenging, and neuropathic ulcers are very challenging, and many causes along with many causes, leprosy also is one of them. And over to you, Doctor.
Good morning, one and all, and thank you very much, Madam, for the wonderful introduction. I feel that I'm an odd man out now, because I'm pitched against the senior faculties of dermatology. I'm the surgeon, standing here to deliver a lecture on neuropathic ulcers of the foot. And rightly said, I was thinking why I've been invited now. Then Jerome Bino sir said, because your name is LL, it stands as lepromatous leprosy, it seems. So that is a very good way of telling me. I should I should thank the dermatology department, especially Dr. Nandakishore sir, who is the organizing chairman for today, for selecting me as a faculty. As the Department of Dermatology has supported me by referring cases of neuropathic ulcers, because when I came back from my fellowship and I joined and I got a unit, I told Nandakishore sir, since I am a hand surgeon, I've been managing some of the nerve injuries, we are doing tendon transfers. Will you be good enough to refer the leprosy patients who are needing hand functional improvement? He said, we have a lot of plantar ulcers who have not been managed, and previously he himself used to operate. I feel Derek Lobo sir used to operate. So he was good enough, and the whole department has supported me by sending patients, and I think what I'm going to show as the past 2 years of my experience and how we can do good for the patients with neuropathic ulcers. I acknowledge the presence of my HOD, Dr. Raghuveer Agdiga. He's also been a constant support for me. So this is the overview of my talk. Now, how the ulcer happens. So whenever you have to manage, you need to understand why it is happening and what happens once the ulcer is happened, and what is the natural history of it, how you can evaluate the patient, and what treatments can you offer for them. Now, this is a question which I asked my postgraduates and the interns who came. So what is the greatest gift of God to the mankind? So they say many options, many options are required. So one of the intern told me, sir, you give me options, because everywhere there is option. Kaun banega crorepati, there are options. So these are the options now we had to give. So organizing chairman is there. So what do you think is the greatest gift of God to you? No, options are, you have to tell one. No options for organizing chairman. No, because it is a neuropathic ulcer, everybody will tell like that. Many people tell it is about love, compassion, wealth, beauty, like that. So I will say this is the greatest gift of God to mankind. It is pain. We say the physical pain as the annoying feeling which we have. We have the mental feeling, it is the agony or the sorrow we have. Then we have one more level which is called as the soul, the emptiness we feel, that is a type of pain. And we, as a gift, when you give a gift to somebody, you want the person who has given the gift or taken the gift to remember the person who has given the gift. I think with pain we'll remember God forever. So I think this is the greatest gift of God. And this is not the first person who was, I am not the first person to say that. It is the Paul Wilson brand. When you talk about the management, you have to remember the people who have worked for it. He is one of the pioneers in the neuropathic food management. He is a UK fellow, but he has been born in India. He was born in Kodimalai of Tamil Nadu. He was born to a Christian missionary people, and he has worked in Vellore. At the Vellore, which we hear now, the CMC Vellore has got his name from this sort of people who have worked for years together. And he has written a book which says that about pain, the gift nobody wants. In the year 1993, I have read that book. It is a fantastic book. Anybody who is interested in neuropathic ulcer and leprosy management should read that. And he said that the loss of pain is the most important reason for the onset of an ulcer in the foot of a leprosy patient. And this is another pioneer fellow, and it is Dr. Hariharan Srinivasan. He is also a Tamilian in Chengalpet. He has worked with WHO and has been tremendously involved in the management of leprosy patients all over India. And he is an Padma Shri awardee. Like Madam has mentioned about Andia, I actually have not spoken about Andia. He is a plastic surgeon. Maybe you can feel that I am an orthopedician. Both of them are orthopedicians. So Andia is another person from Bombay who has worked a lot in the treatment of leprosy patients. The pathophysiology of ulcer in leprosy need to be understood when you go into the management part. And the picture is quite varying, and the ulcer appears in different sites and different modes. Now, why does the ulcer happen? It was not a straightforward thinking that ulcer happens because of this. The initial part of the 20th century, people thought it is because of infection why the ulcer is happening. So we attributed that the Mycobacterium leprae enters into the tissue. It causes the tissue to go for lysis, and the ulcer happens. So it was said that the tissue gets rotten away and it just drops off. But this was true for maybe much of the lepromatous cases, or the face deformities you could explain in that way. But that's not the case with foot ulcers. Most of the pus discharges did not grow the bacilli which you wanted. So the people start thinking that maybe it is not the direct infiltration which is the cause for the ulcer. Then the starting of the 21st century, we saw the more and more knowledge about neurology. When we started attributing all the problems in leprosy because of the neurological problem. So we said that there is a motor part, sensory part, and there is something called as a trophic nerve, which maintains the well-being of the tissues. And that may be the reason why that trophic nerve also is affected. It may be the reason for this sort of an ulcer. And that's how the name of trophic ulcer came into being. But the researchers was not able to find exactly locate this trophic nerve, which we closely say that it is the autonomic nerve which is close to the trophic system. And this is the one which stood the time to say that it is the loss of pain sensation, which is the main culprit for the development of neuropathic ulcers of the foot. And the loss of pain sensation makes the patients to neglect the trivial traumas which we also develop day to day in our life. And this was another theory which was put forward. It says that the ulcer which is there on the foot is because of the pressure or the shear force. It is somewhat like a pressure sore which we develop on the bed, or the bed sore, or the decubitus ulcer. And there is an associated muscle weakness. When you have to walk, we normally have a gait which is being controlled by the intrinsic and extrinsic muscles. And because of the leprosy, there is weakness of the muscle, so there is excess of loading at particular point, and that load leads to tissue pressure excess, and it leads to tissue necrosis. And this is the picture which you can show there. This was the ulcer on the great toe area, and that is the inverted cone which you normally get in a decubitus ulcer, where the tissue damage is more in the deeper part because of the shear. And this, people started believing that it is because of the pressure, so you offload him, he will be all right. But if you see, this is the pedoparachoric picture of a person who normally walks. The maximum pressure is over the heel, and it is less, or the red part is the maximum pressure, yellow is the moderate, and the blue is the little less, and the green is a little less, and the blue is the least. So if you see, when a person normally walks or stands, his maximum pressure is at the heel. So normally if it is because of pressure effect, he should have had ulcers, or the neuropathic ulcers should have been maximum at the heel. But if you see, most of the patients develop maximum pressure in the foot, or the ulcers in the forefoot region. So which says that it is not exactly or entirely due to the pressure effect. So where do you stand now? So this is the last final description I could get for to say that why a neuropathic ulcer happens. Predominantly it is because of the loss of pain sensation. Paralysis of the intrinsic and extrinsic muscle leads to excess pressure and shear, and this excess pressure and shear is loaded to a particular point when you walk repeatedly. But once the ulcer happens, whatever may be the reason it is happening, the natural history is independent of the etiology. The ulcer goes through 3 stages. We see patients in all these sort of stages: the stage of inflammation, the stage of necrotic blisters which happens, and we have the ulcer patient who is having an ulcer for a long duration of pain. So predominantly what we see as surgeons is at this stage. Other than the ulcer, that is a tissue breakdown, we have a problem which is the main skeletal framework is affected. It's because of the autonomic dysfunction. There is excess of blood flow, and the bone undergoes resorption because of excess of osteoclastic activity. So there is a destruction of the bone, and which further adds to the pressure effect. So finally what happens now? The beautiful foot is turned out to be something like this, where the skin atrophies and the whole shape of the foot varies, and there is a resorption of the bone. So this is another to show you about the Charcot's joint or the Charcot's arthropathy which is happening. This is the normal foot, where you have the normal x-rays and all the normal tarsal bones are there. And this is the final stage in which there is the collapse, the mid-carpal collapse. And if you see here that this is the talus bone, and these are the metatarsal, the in-between cuneiform bones is resorbed or disappeared. So there is joint damage, and plus there is bone resorption, making the things very difficult. Now, next we go into the evaluation of the patient. So I have talked about the pathology, then now we are going to see the evaluation of the patients. So all the patients who come to us are of varying times, and what they uniformly want is an ulcer-free period. They say, I'm fed up of treating this, dressing these wounds. I want to go out, meet people, interact with them. Because of the smell, I am not able to. I think that has been that we have been trying to do. So the history, how long has been the disease? How long is the ulcer? That is also important for us. And associated problems like diabetes and all add to our treatment problems, and the habituations, especially smoking. These 3 parameters have been very important for us to say how the patients respond to treatment. First is about the occupation. I have seen that patients who are occupied have got a tendency to get better and get back to work faster, but a lot of recurrence, because most of the manual laborers, they can't comply to our footwears which we give, so they come back with the recurrence. So we keep a note on the occupation of the patient. We tell them how much of time he can walk, and all these sort of modifications are described. Understanding and disease of the disease and motivation of the patient is very important for us, and who supports them financially, because once the treatment starts, some of the patients leave in between and they come back after some years. It is very difficult for us to get back to them, get them again. Now this patient is there in our dermatology ward now. She is the bed number 28. She always comes to bed number 28. I wanted to ask her whether it is been reserved for her. She is having a claw deformity, and initially we had a debridement of the heel ulcer. So we had done a workup, and we told her, see, you have got a claw deformity. You have some problem in the right side, but the left side also is having some problem. Shall we treat you? She said, no. Past 65 years I have been going on like that, and many people have operated. Even Nandavishwar sir has operated on me, but nothing good has happened. A joke, sir. So this is a problem which we face. Even though we know that the patient is there and is in the stage of impending ulcer, we tell them that, see, we can do something for you. They say, no, you just leave me, give me some footwear, I'm happy with it. So yesterday I was speaking to one of my classmates, colleague, he called me night. I said, I'm preparing for my talk. He said, what talk? I said neuropathic ulcers. He said, what, you give a footwear only? No, nothing more you have to talk, he said. So that is a general perception of the people who say that for you have neuropathic ulcer, you just give a footwear, everything will be all right. So ulcer examination, we follow the same steps like size, margins, edges and base and the floor. And we go into the neurological examination. Now we assess the sensory part. We don't go into the vibration part and all, which we know that it is lost. We are concerned main about the loss of pain sensation. So we assess the sensory level. This is the Siemens-Vincent's monofilament we have with us. And it says that the green is the normal, then we have the blue, then we have the violet and the red. Up to violet and below, we have protective sensation. And if the patient is having up to violet, he says that he may not develop an ulcer. But if it is in the red zone, he is prone for an ulcer. In the motor evaluation, I have put into the extrinsic muscles and the intrinsic muscle. The intrinsic muscle functions are normally not tested by everybody. What we need to know is the flexion of the metatarsophalageal joint of the great toe. That checks for the integrity of the abductor hallucis and the flexor hallucis brevis. So you can see here the person is asked to flex the metatarsophalageal joint. In the same way, the intrinsic functions of the abductor geniculum minimi and the interossei is checked by asking the patient to fan the toes out and bring it closer. So you look for the abduction of the metatarsophalageal joint of the little finger, little toe. We do radiography and CT and MRI to know the effect of the ulcer onto the bone, to know whether there is an osteomyelitis, whether there is a destruction of the joint. MRI is done when you feel that there is a persistent infection, which we feel that it has been involving multiple bones, because we need to have a plan of debridement, how much to debride, and for that. And Doppler and CT is reserved for patients when we feel that there is a little reduction in the blood flow to the lower limbs. And this is one of the main armamentarium in our evaluation of the patients. We do piezobarography for the patients before surgery, if possible, and even after surgery. So this is nothing but it is available in our physiotherapy department. And Dr. Kavita is there. Now, we have our HOD, she is very good in assessing the piezobarography. I invited her. So we have a pressure plate on which, and there is a sensor, and this sensor reads the static pressure of the foot when the patient stands, and that you get it as a recording. And that's how the test is done. And you get the maximum pressure on the left side. This is what you're seeing from the top. So this is the right side and this is the left side. So we have the right side in red and the left side in green. We have the maximum pressure, the pressure distribution in the front and the back, and even we have the pressure distribution in the percentage in each areas. The red again says that is the maximum pressure, or the area where the patient is putting maximum. And we can see the surface area of the foot also. So we get a lot of details about how the patient is putting pressures when they are standing. We also do a dynamic study. That's a dynamic piezobarography, because the static and the dynamic may not be the same. So that's the way the pressure is being distributed when the patient is walking. The piezobarography also varies based on what the patient is having, especially in a foot drop patients like this we can see. This is our model, our intern. So when you stand, it's exactly like a normal person. The maximum pressure is over the heel. But when the patient is walking and the right side is the affected side, you can see that the normal gait cycle, our heel has to touch first, and then it goes to the foot flat face and the toe off face. But in this, what is happening is that the forefoot is touching down. So when the patient is walking, he will have excess of forefoot loading, and the patient is prone to have an ulcer in the forefoot.